is Michael Krasowski from Agewell, and welcome to this latest webinar in partnership with Agewell and the HSN network. And I'm going to hand it off to Nigel for our introduction.
Okay, great. Thanks very much, Michael. It's great to be here again. This is now what is the fourth event of our UK Canadian Innovation Exchange series. Obviously, we're focusing around healthy aging, but this evening or this morning, if you're in Canada, we're going to be looking at growing the longevity economy. And we've got a great lineup of speakers for us today. I'm really pleased to or want to give thanks to Health Innovation Manchester, who's pulled the programme together for the UK end. And I'm going to embarrass Omar and say thank you very much for dipping out say thank you very much for dipping out of your honeymoon to spend time with us. Really appreciate that. So I know quite a few of you won't have joined these events before, and what I wanted to do with Michael is to give you a quick overview of Agewell and the HSN network and what we're wanting to do with this Innovation Exchange programme. So I'm just going to share a couple of slides with you, just as a prelude for that. So have you got my HSN network slide up there? Yeah, great, thank you. So the Academic Health Science Network is funded by the National Health Service and by what we call the Office of Life Sciences. There are 15 networks or 15 members of the network around England, and you can see the map there, and you've got the URL. We've been described as the innovation agency for the NHS, so our job is to speed up the uptake of innovations into the health service, into the care and health service. There are four elements to what we call our innovation exchange. So we articulate the needs of the NHS to innovators, so that's needs definition. We're here to support innovators to get to develop their innovations, to evaluate them and to get them used. And as part of that, we support what we call real world validation. So that's the real world evaluation of those innovations in care and health. And once the value is proved, we support the spread and adoption of innovation. And if you want to know a little bit more about what we do and the support that we can offer, again, you've got the URL for the Innovation Exchange there. So over to you, Michael, just for an overview about Agewell.
Thank you, Nigel. So hi, everyone. I'll just be brief here and tell you a little bit about our network. So Agewell is Canada's Technology and Aging Network. We've been around for a little over 6 years at this point. And our mandate is really to support innovation and technology benefiting older adults and caregivers. We've been doing that by funding research throughout universities across Canada, as well as engaging partners from industry, not-for-profit sector, community groups, and government. We've worked with over 400 partners to date, all working together to kind of connect the dots and ensure that technology can provide those benefits. We also work with 4 great national innovation hubs, one of which you'll be hearing from today, that help us look at different areas related to technology and aging. And all of that is to say that as a network, we try to connect researchers, startups, companies, community groups, and probably most importantly for us, actual older adults and caregivers that are meaningfully engaged in our network, all working together to ensure that we can develop technologies, solutions, services, and the policies that enable them that can transform care and quality of life for older Canadians and older adults around the world. So we're pleased to collaborate with these sessions with the HSN network, and looking forward to engaging with you both today and beyond. So thanks, Nigel.
Okay, great. So what did we want to do with the UK Canadian Innovation Exchange? Well, we've got some very simple aims, which I'm just sharing with you here. So we want to build collaborations across academia and health and commercial entities to support better delivery of health and care. We want to help to exchange knowledge, and this shared webinar programme is part of that. And also what we want to do is to stimulate economic growth and work with innovators to do that. So we share this common aim around aging well. The program is very straightforward. So we aimed in this first year to hold 4 networking events. So this is the third this calendar year, although the 4th in the series. And we've also got a LinkedIn group for innovators. So if you search on LinkedIn for UK-Canada Age Tech Exchange, you will be able to find the LinkedIn group. So we've really not promoted that very much at the moment, but we're going to start promoting that, and we hope you will find that a useful resource. And we also have resources on our respective web pages. And we've also, you'll find on those web pages access to the recorded materials, some of the previous events. So we had a really good session in July around the role of robotics in supporting care for older adults, and you'll be able to find the recording of that seminar together with some of the earlier seminars that we held here on the Agewell AHS Innovation Exchange webpage, which you'll see there. And obviously, for those of you who are picking up on the recording, you'll be able to pick that up. Just to look at what's ahead, we're planning in January an innovator showcase. So probably late Jan, and we'll be circulating a call for expressions of interest for innovators who would like to pitch their innovations to this international audience. We'll be circulating details of that to you as a follow-on email in the next few weeks. Okay, so I won't take up any more time, so I'm going to hand back over to Michael to introduce our speakers.
Great, thanks, Nigel. And today we're going to start off with Greg Christie, who is the CTO at Digital Health Circle. So Greg, I'll hand it over to you.
Okay, wonderful. Thank you for the introduction. Thank you everybody for being here. It's a pleasure to see in chat a well-represented group from Canada and the UK. So to everybody, good morning, good afternoon, and good evening, depending on where you happen to be in the world right now. So my name is Greg Christie. I'm Chief Technical Officer at DHC. We are a nonprofit innovation center headquartered in Vancouver, British Columbia. I would just like to begin this presentation by acknowledging that as entities on the west coast of Canada, we are on unceded traditional territories of the Coast Salish peoples. And at DHC, we acknowledge our commitment to reconciliation with Indigenous persons in Canada. So I'll give a fast outline on my presentation for you today. So I'll go into initially some background on what brought DHC into existence and what are the challenge areas that we are looking to assist with as part of our broader network. Then a outline of what we are as an innovation center and the model that we approach for supporting innovation between solution developers and healthcare stakeholders. And then I'll close this off with a practical example of a project that is still in flight right now that we've been supporting for about 12 months. It's one we're very proud of, so I'll be happy to show that in a second here. Okay, so as background, the impetus for digital health tools has certainly been growing over the span of the last 10 years and arguably very much so over the last year and a half in response to COVID-19. And it's being driven by sort of a collection of several different factors. Obviously, one of them relates to the increasing cost of delivering healthcare, regardless of geographic area, whether it's Canada or the United States or other countries in the world. In no small part, this is being driven by demographic changes that we're seeing in Canada. The global number of people over the age of 65 is anticipated to reach 2 billion persons by the year 2050, for example. And so this is leading to an increase in complex and chronic care management in a way that's difficult to scale affordably and sustainably using institutional healthcare practices. This is being combined with a growing desire for health self-management across the lifespan, not just from older adults, but across the lifespan. And then, of course, most recently, COVID-19 has been an exigent sort of set of circumstances in terms of how people even access health resources in the first place. When you may not be able to even go into your physician's office, for example, on account of stay in place and shelter orders. Collectively, what this is doing is driving a very large demand for digital health products in a way that in Canada is a bit new for a number of stakeholders. And so getting to why we exist as an organization, we're here ultimately to assist with that process. But before getting there, I wanted to highlight the demand for digital health and the current state of affairs in Canada. And if nothing else, to dispel a bit of a misconception here around the role of technology with older adults. So about February of this year, deep into the COVID pandemic, we commissioned a market study with British Columbians to assess what their response has been to using digital health products over the COVID-19 pandemic. One of the questions was around their perceived satisfaction with the availability of tools and their perceived self-confidence using digital health tools. And what we found was that individuals over the age of 55 were by far the most satisfied with the availability and utilization of digital health products. So just to dispel right away that this is not a demand that's being driven necessarily by younger people. There is very much a desire for these technologies, these services amongst people who are older and who might be engaging with healthcare in a more active way. The other factor to highlight comes from the production of digital health technologies, which is almost exclusively being driven by agile and small organizations. The numbers on this slide here pertain to the economy of British Columbia, so this is Western Canada. In our province, of those employed in the private sector, it is almost exclusively dominated by companies of less than 500 employees. 88.5% of people are employed or a small or medium enterprise in British Columbia if they're working in the private sector. And this is contributing by itself 58% of British Columbia's GDP. So extremely important across all economic sectors. And I should highlight as well, this is also the region of British Columbia's economy that's been the most negatively impacted by COVID-19. The greatest number of job losses and the greatest amount of economic loss over the last year and a half has been experienced inside of this segment. So this points to a combined opportunity here for a growing opportunity for the creation of digital health products, and an important piece for economic stimulus and economic recovery in our province as we look forward to the end of the COVID-19 pandemic. Now, this sounds good, but there are a number of challenges that small industry is confronted with when they're creating digital health products. And I usually say that this combines all of the challenges of traditional digital technology development with all of the challenges of health technology development. So this is often a very difficult space to be an entrepreneur in creating products. I think the root challenge for most industry is around accessing stakeholders and the knowledge that they possess, at least inside of the Canadian economy and whatever international markets they may be looking at. And it's worth remembering that there are a lot of stakeholders inside of health technology. This can include healthcare professionals, so doctors and nurses often come quickly to mind. Obviously, it includes patients and end users and the people who will actually be impacted by a technology. Caregivers, of course, are an important part of this as well. But it also includes whoever is going to be purchasing this. And very rarely is that one of these first two groups. It's often insurance companies or government or employer and wellness programs or somebody else. And so each of these stakeholders often has distinct value propositions. And small industry has to create products that address these value propositions. It's not good enough to just create a product that patients like to use if there's no reimbursement pathway, for example, for medical doctors to prescribe it. Often it's necessary to demonstrate efficacy and demonstrating return on investment, particularly to whoever is going to be paying for this. And this is a notoriously challenging problem to demonstrate in the digital field, particularly for preventative health tools. And underscoring all of this is complex and difficult to forecast development costs. And again, these are small industries for the most part who are developing these technologies, often underfunded, undercapitalized. And so it's very difficult to be able to create products with unclear development costs and schedules. And so the crux of the challenge becomes a disconnect between those in healthcare responsible for providing health and those in industry who are wanting to create products to assist with that process, where government healthcare often understands a problem, but has difficulty communicating it to small industry. And small industry has a desire to create products, but often lacks understanding of what it is that they're trying to create and solve. So this is the impetus for the creation of our innovation center. So we are a nonprofit innovation center. We're headquartered at Simon Fraser University in Western Canada, in the city of Vancouver. Our mandate is to support the creation of technologies that improve the health and quality of life of Canadians across the lifespan. And the way we do this is largely inside of two verticals. The first is to be assisting with scale-up companies to connect with stakeholders, to understand the context in which they're developing a solution and how it will be utilized, and ultimately to ensure that their technology, that their product is going to be successful. It's going to be effective at solving health challenges, and it's going to want to be used by stakeholders. And then the second area where we assist is by reducing development costs to small business. And I should clarify here, we work with a subset of small industry that we call scale-ups, sometimes also called high growth potential companies. So these are companies that are past the startup stage, who understand how to generate revenue and have investment, often already have existing products, but are experiencing challenges with the new product development. We are a network, pan-Canadian and actually international as well, some of our partners, including obviously members of industry. Now, inside of industry, for the most part, our region of responsibility is British Columbia. So most of the companies that we work with are local to us. But growing beyond that is less so. We work with a number of nonprofits, including patient advocacy groups and technology associations, patient advocacy groups, I think I already mentioned, number of universities and research institutions across North America and internationally, and of course, a number of government and para-government agencies. This includes healthcare providers in Canada, in addition to other funding agencies who have a mandate for supporting technology innovation and health. And the way we work is with a model that we call collaborative co-creation. So this is an approach to solve the challenge around stakeholder engagement. So when we work with industry and other stakeholders at the same time in product development and product commercialization. So all projects that we select always involve stakeholders from as many of these groups as we can. Now, not all groups all the time, but we do look for, at a minimum, industry, health systems, and at least one other stakeholder, whether it's coming from government, academia, or community, on sort of a case-by-case basis, depending on what specific R&D challenge we've been asked to assist with. And when we work, we fund projects we fund on a project level basis, and we work a little bit differently from other funding agencies in Canada, where industry is contributing directly to project costs. We're able to access government funding to partially offset the costs of this. And then we fund collaborative projects directly, as opposed to funding university partnerships or working on a cost reimbursement model, which are the two common approaches for project funding in Canada. So as an example of a collaborative project that we've been supporting, as I said, for about a year now, comes from a request to us from Fraser Health Authority. This is one of the large health agencies in the province of British Columbia. The request was for assistance with mental health and substance use among frontline healthcare workers, particularly during the COVID-19 pandemic. Now, the challenge here is particularly sensitive. Alcohol consumption is already one of the most stigmatizing health and mental health conditions in the workplace. Very, very rare to have employees approach their employer and say, I'm struggling with alcohol use and I need assistance with this. This is made doubly worse in a healthcare context because there are actually legal implications potentially for nurses and physicians who report that they have a substance abuse problem to their employer. So Fraser Health was aware of this and approached us asking for assistance with the technology that could achieve a few outcomes here. The first is that it had to be privacy, not just privacy compliant, but privacy respecting at all points. So it needed to be a technology that its employees could access in a totally anonymous and private way. And it needed to be non-disruptive. So as opposed to conventional rehabilitation programs where you might be gone for 30 days for a rehab program, that's obviously not something that is feasible right now during COVID-19. So this needed to be non-disruptive, and it needed to be a solution that employees would be able to access where and when they needed it, as opposed to conventional therapy where effectively you go to see your counselor or your therapist whenever they're available, not whenever you're available. So to assist with this, we brought together a network of stakeholders. This included experts inside of Simon Fraser University in the space of mental health and addiction, funding from the BC provincial government and also from the Canadian federal government as well. I didn't have space to include that in this slide. We worked with a private industry developer in British Columbia called Alavida, which is has been creating an alcohol reduction app, mobile app for this. In addition to members of the community who are also participating in this study to evaluate the product during its development. As a deliverable or a set of deliverables out of this product, out of this project, there were four major ones. So the first was to develop new outcome guidelines in terms of how to assess the successfulness of a substance use reduction program. This may sound rather straightforward, but it's actually a deceptively thorny issue about how you define successful reduction in alcohol consumption. There are at least 3 or 4 different major axes where that can be defined. So that was very important both for Alavida on the industry side and also for Fraser Health to be able to understand, is this application actually effective overall in reducing alcohol consumption? Part of this was an assessment globally of what has been the impact of COVID-19 on mental health and substance use rates, not just in Canada, but across the world. This helps to show that there's an opportunity for this product, not just in Canada for Alavida, but globally as well. It led to the development of a product called the Trail Substance Use App by Alavida. And it led to the deployment and the assessment of the Trail app inside of Fraser Health with its personnel. And then key results, just to finish this off here, we're proud to say that the Trail app has been made freely available to 30,000 individuals inside of Fraser Health. As it is right now, approximately 300 people are engaging with the app currently. And this has led to a negotiated contract with Fraser Health and Alavida for continued availability of the app going forward into the future. And then most recently, Alavida has undergone an acquisition by another Canadian digital health provider for a total valuation of $12 million. And this is brand new. This just came out on Friday. So we're very proud for that. And if anybody is curious, the website for Alavida is alavida.co. So thank you very much, everyone. Obviously, we'll save questions towards the end here, but I look forward to seeing them in the chat. Thank you for your attention and have yourselves a very pleasant day.
Thanks so much, Greg. It's great to see those high impact projects that you guys have going on and the approach you're taking, which is very collaborative, obviously. So thank you for that. At this point, we'll hand it over to Michael Ferguson, who's the CEO and co-founder of Agewell. For your talk. Michael, you are on mute.
Yes, of course I am. And then, of course, my windows are all hidden. But thanks very much for asking me here. I just want to start by, by acknowledging this important question. Ayogo who, which is partly, I'm sure, a question that many of you are asking, hoping I'll answer in my talk here, but also a question that gets asked generally and is a challenge for any SME to establish credibility in the asking of questions. There is a sort of a vicious cycle there of needing credibility to ask questions in order to get the answers that afford you the credibility that allows you to ask more questions. And it's very important, the relationships that we have with Agewell and Digital Health Circle and the work that we've previously done with the HSNs, and in the UK we've done some very rewarding work with Wessex in the pre-COVID period that we're really proud of. this is sort of the underlying theme of my talk here, is the importance of these partnerships to giving our company the ability to ask the right questions so that we can then follow our thread of research. And I want to just, acknowledge one more thing, which is that it's easy to think of industry and SMEs as being, defined by our business models, but and our for-profit status. But in actual fact, Yo was not especially unique here. We really think of ourselves not as our business model or as the type of company or organization we are. We think of ourselves as a collection of people who have a mission. And, our mission is to change people's lives for the better. And profit is a means to that end, not the end itself. So, what is the ship that Ayogo built to navigate the sea? And we developed, as part of our startup phase of a company, we developed a platform that we call Lifeplan. Platform as a service, built specifically to overcome unique psychosocial barriers each patient faces along their individual care journey. We observe that the barriers to accessing care, to appropriate self-care behavior, to information seeking and education seeking behavior, those barriers vary from person to person. And it's very important to give people the right things at the right time. The right thing at the wrong time is very, very similar to giving them the wrong thing. And it's important to try to understand individual people. That's been our mission as a business. And, without spending too much time lingering on the underlying product, we think of this as offering value to what we see as being, key stakeholders in the system that we engage with: patients, healthcare providers and healthcare systems, and pharma. Our product, although you might call it a digital therapeutic, is not directly therapeutic. We wrap our behavioral support wrapper around existing therapeutic devices, drugs, or programs to help patients navigate their way to those therapies and utilize them effectively and be persistent in their use of it. There's a lot that could be said on this slide, but just to illustrate that, we exist in a complex multi-stakeholder environment, and we spend a lot of time thinking about how we create value across the whole spectrum of stakeholders that we engage with. And we've had some excellent results, thanks to our partnerships with Wessex and organizations like Digital Health Circle here in Canada. We've been able to establish some credibility for ourselves and won some awards, had got some very, very complimentary quotes, and been consistently recognized for the quality of our work. This is, of course, very meaningful to us as individual people inside the company. What we are here to do is to do our best work and to change the world and hopefully enjoy ourselves a little bit while doing it. 80% of search traffic is from mobile. We're all moving online. Just to echo what Greg said earlier, we're not just moving online, we're moving into our devices. And this is how we connect with each other. Smartphone penetration among the what we might call the younger set is virtually 100% now. And the web's the primary source for health information. In fact, the data that we gather for ourselves and use to make our own healthcare decisions is increasingly concentrated on mobile. And yet, virtually all patients have had an experience of frustration with the device, and many of them have had the experience specifically with healthcare devices. And applications, not being able to accomplish what they needed to get accomplished in a digital health app. Well, that's a tremendous opportunity for us. We look at that statistic and we see an opportunity. This is the problem that Ayogo and other SMEs like us exist to solve, precisely this problem, to ensure that people get what they need when they need it, and that they can successfully navigate it. There was a good study published earlier this year that we really like a lot about the role of digital health in the management of non-communicable diseases. Multi-stakeholder advisory board provided the following feedback: that goals of patients differ from those of healthcare. And I'm acknowledging here that I'm saying what I expect everybody here knows already, right? This is what we know. We know all together that the goals of patients and other healthcare professionals are different. We know and want and need patients, healthcare professionals, caregivers, other end users to be involved from the earliest possible moment in our innovation cycle. And we know that these digital health tools need to be better tailored for people with complex conditions, multimorbidity, older age, cognitive, sensory impairments. These are very, very challenging to design for. The differences in goals and objectives take time to resolve. Complex stakeholder engagement is hard to do. It's hard to keep all those stakeholders engaged over time, especially if you're a small company. And even the problem of designing for just for patients alone, the interfaces is even more complex than it looks, because patients are simply not a homogeneous group. This is challenging and expensive and resource intensive. And I'll let you in on a secret. Every SME has got a zero cash day. Well, that's not the secret. The secret is that zero cash day is a lot closer than you think. And that day for us means we go entirely out of business when we hit that day. And so we are always very carefully, all of us, all of our companies are very carefully watching that day. How close is it to us? Carefully managing our cash flow and our runway. We simply cannot run out of money because the pool of money that we draw from pays for everything that we do. And, being venture backed and pre-revenue for the most part, our innovative companies need to manage resources and time, especially carefully. And, to our rescue is organizations like Digital Health Circle. And I'm just going to talk a little bit about, we've done a fair amount of work with DHC over the last few years, in particular in chronic kidney disease, which is an area that I expect is of particular interest to people on this call. I'm going to focus on a slightly different project, a more recent project that we worked on together. Together with our friendly partner in Digital Health Circle, to do things that we would not have been able to do on our own. We did not have the credibility as a company to create a broad-based stakeholder advisory board with the time and resources of people we had available. We were able to do that. We were able to consult with dozens of patients and physicians throughout the design and development process of our new application, and create, validate, iterate, and approve hundreds of individual pieces of content, videos, articles, papers. This is an enormous amount of work and incredible amount of production for what was, from a Yogo's point of view, a team of 3. We would not have been able to do it without the support of Digital Health Circle and in our work in the UK and pre-pandemic period with the support of our partners at Wessex. In the end, just to give you a little vision on what was the end result of that project, we were able to identify a use case, an unmet patient need that we had not thought of before, which is that for this particular group of patients that we were talking about, which is in this case, patients with RR, MS, and multiple sclerosis, is that many of them are parents. And the condition does not simply just affect them, it affects their children and therefore affects their parenting, and makes it, this uncertainty affects their whole family and affects their ability to manage their conditions themselves, manage appointments, and of course, creates anxiety. And the statistic that I'm most familiar with is that upwards of 90% of patients with MS suffer from depression to a greater or lesser degree. And our discovery in the research that we were able to do, again, at a scale where it produced an insight like this, only because of our engagement with partners like Digital Health Circle, was that this parenting use case was especially important for us to address. So we were able to create an application that specifically addresses that use case, test it effectively, and get it to a place where it is able to be deployed in a time frame that simply would have been unapproachable by our company on our own. This is the power of collaboration and the power of our companies and our organizations doing what they're best at, but working together to accomplish a result. I'm going to leave it there. There may be some more specific questions about how we worked with Digital Health Circle and previously with WESX, I'm happy to answer those questions and I look forward to them.
Hey, thanks so much, Michael. It's always, I think, worthwhile to remember that there are a lot of really innovative companies, including Iogo, that can do quite a bit on their own, but can also benefit quite a lot, both in terms of sustainability, but also accelerating their impact through creating supportive ecosystems. So thank you for speaking to that as well. And yeah, we'll look forward to questions for both Michael and Greg later. At this point, I will hand it to our next speaker, and that would be Paul McGarry, who's I guess wears a few hats, so maybe I'll let you introduce yourself, Paul.
I don't know what you've heard, Michael. I've got maybe two hats. So yeah, I'm Paul McGarry. I'm Assistant Director at the Greater Manchester Combined Authority. And I head up something called the Greater Manchester Ageing Hub. I guess I'm 80% bureaucrat and 20% sociologist. Depending on the audience and the room I'm in. And I have a research fellowship at the University of Manchester with the Manchester Interdisciplinary Research Team there on ageing. We've also got Sig from Greater Manchester at hand to take part in the discussion and hopefully answer some of the trickier questions on the kind of digital side. It's not my, well, what I want to describe really, I guess, is the broad approach we take in Greater Manchester around ageing and healthy ageing, and where a range of kind of digital stories and narratives fits into that. And then we've got a practical example from Lee for you to hear about how the system works. So Greater Manchester has a population of 2.8 million people. It's 10 municipalities, 10 local authorities. We have some devolution around health and social care, work and skills. We have a public sector budget of something now around over 20 billion pounds. Health budget, annual budget of around about 6 billion pounds. And we have a wide range of assets and expertise in our universities, local government, and many other institutions around this agenda. Where I come into the story really is through leading or helping to develop an ecosystem across Greater Manchester, in some ways similar to the shape of things that Greg described in his introduction. Our approach, I guess, is based on the WHO Age-Friendly Citizen Communities model, which partially originated in Canada from some of your researchers, I think in Ottawa. We have worked really on trying to develop a strategy for Greater Manchester, which looks at a number of themes around ageing. And then I'm going to try and draw out some of the digital implications of that and where we are in terms of our innovation partnership for healthy ageing. So we have a set of task groups and action groups around older workers. We have a group that's looking at how we can support people to work into their 50s and beyond. And the types of measures that we need to take there. We have a large program around housing, planning and ageing. We've just published a new framework for Greater Manchester, which is in part focused on engaging with the private sector, with developers and funders who are entering this space, and trying to link up the agendas around retrofitting and the environmental agenda alongside ageing, and I guess the smart technologies agenda as well. So how we can bring those things together into, first of all, into new build, but also into the existing housing stock. We have a programme which is led by our NHS colleagues on healthy ageing, which looks at many of the, I guess, the health conditions that people experience in later life around malnutrition, physical activity, mental well-being, so on and so forth, which is, I say, led by our NHS colleagues. And a significant programme that we have and have worked on, I guess, myself in a number of roles over 20 years around neighbourhoods and ageing, or ageing in place, or age-friendly neighbourhoods, whatever you want to call it, as essentially the key theatre for understanding the patterns of everyday life that older people engage in, and the support and help and the platforms that they need to maintain independence, interdependence, and so on and so forth. And our mayor, our elected mayor, Andy Burnham, was recently re-elected earlier this year in May, and one of his priority areas was around digital inclusion and older people, on other groups as well, but he made some manifesto commitments around older people. And I think what this has uncovered is a really profound and significant conversation, first of all, between representative groups of older people that we supported in Greater Manchester from a range of different communities and neighbourhoods. First of all, with public services. Secondly, with, not least with the NHS at the moment, secondly, with private companies, with each other, and with community organisations that support them. So with our digital hub in GMCA, linking with across the universities and other institutions into the telcos and so on, we are working on a significant programme around digital inclusion, and that really is at all the different elements, not least actually because of the, I think, as colleagues have already suggested, COVID has accelerated the move for many services and many people into the digital arena, to the digital world. And the risk is, as public services and private services do that, they leave behind. There's a kind of, I think, there's a dividend that they have to pay in terms of supporting those older people furthest away from the digital services onto to support those services. So, as I mentioned, we're organised around a series of different themes and so on. I should say there are a couple of things as well which underpin our approach, is, I guess, the concept of social inclusion and the focus on inequalities. And I guess one of the risks in this area as we move forward is the risk that those on low incomes or in low income communities or marginalised groups will fall further behind as they tend to be less users of digital platforms, have less access to some of those services and so on. So we're keeping a very, very keen eye on the risks around inequalities. I just want to move on really for a few minutes to talk about our innovation partnership for healthy ageing. So Greater Manchester, along with central government, I guess it's pre-COVID, so whenever that was, published an industrial strategy for Greater Manchester, and one of the areas that we highlighted was around ageing, and the vehicle to develop that work is this innovation partnership. And really, I guess this is trying to satisfy a number of objectives. It's trying to work out how Greater Manchester PLC can create more businesses and jobs around healthy ageing and improve outcomes for older people. And one of the advantages that we have is that we've been involved in developing this ecosystem. I think it's what the Europeans call the kind of quadruple helix around citizens, businesses, public sector and private sector agencies, trying to work out how we address these challenges and opportunities of ageing populations. So the IPHA has been set with this task of developing a programme of work, and there are a number of components to it. It's chaired by a local economic partnership, and it includes stakeholders from national government, from UKRI, from private sector agencies, local government, the NHS, and many other institutions. And it also sits alongside our GM family of organisations such as Midas, which is our inward investment agency, Transport for Greater Manchester, that is doing some fascinating work around, I think, older people, and Health Innovation Manchester. So we have a number of projects up and running, some of them in the digital space. We have a pipeline, an innovation pipeline, specifically around supporting SMEs on this agenda, trying to plug them into the right support. So our innovation partnership has a wide range of interests and thematic working. We're also working with central government to be a high potential opportunity area around diagnostics and healthy aging, and that programme brings together a wide range of institutions in that space. It's not my area of expertise, but we have significant assets in that work. I just want to finish off by saying 2 or 3 things, I think. I mean, our work, I think, essentially, is about how do we connect. There's a great, I think, illustration earlier by one of our colleagues. How do we connect the different elements of the system to create better outcomes for our citizens? We have some of the worst health outcomes in the UK for older people in Greater Manchester. A number of our local authorities, such as Manchester and Thameside and Salford, have amongst the worst health. So there's absolutely a focus on engaging and mobilising these assets, community organisations and others as partners in this endeavour. And also bringing those together in spaces with our colleagues from our key universities across a number of different disciplines. So we are keen to participate, we are keen to collaborate. We do in the UK, we're keen to collaborate internationally. We have lots of connections in Canada, not least with through the WHO. I'm speaking at Niagara Falls later this year, or well, at least from my kitchen to Niagara Falls, the IFA conference. We're looking to create those partnerships and support each other in what is right now, a hugely important area of work. So I'll finish there and look forward to the conversation and comments.
Great, thanks, Paul. Thanks so much for sharing all the work that you do. The last speaker we have today is actually really going above and beyond, and that is Lee Omar, who's the Chief Innovation Officer and founder of Safe Steps. So Lee, look forward to hearing from you, and thanks again for making the time during your honeymoon.
Thank you, Michael. I'll just share my screen. Get to see my messy desktop. Just one moment. Excuse me, just turn it down for 5 minutes. Sorry. Someone mentioned Niagara Falls, and just a little aside, was where I proposed to my wife last year on the Canada side. So I didn't get to go to Buffalo because they closed the bridge, but wonderful part of the world. So yeah, love to collaborate. So yeah, my name's Lee Omar. Excuse me for the noise. It's 7 o'clock here in Greece. I'm in a restaurant, so it was the quietest place I could find. But so yeah, my name's Lee Omar, and I'm the founder and CEO of Safe Steps. We're based in Manchester in the UK, but we work all around the UK, mainly with the NHS. And I'm going to talk a little bit about my journey in digital health, because it's relatively recent, and what I've been doing since the pandemic. And a lot of what Paul said really resonated with me, because as he was talking about these terms like the quadruple helix, I remember hearing this a few years ago, and I had to Google it. I was like, you know, what is this? I found the triple helix, and then I thought I was up to date, and then it was a quadruple helix. But you know, I'm really proud that we're based in Manchester, because that's what they're all about. They're all about people first. They involve industry, academia, and government to, you know, to change the world for the better. And it's a great place to be based. So yeah, here's me with my granddad, Frank Omar. He's passed on now, but he's very much my hero. And while I was running my tech company, I was also a carer for him, part-time. It was my job to go and see him in his flat every morning and wake him up for breakfast after my nan died. And he was starting to live with dementia, and he had cancer. But, you know, we didn't want him to go into a care home, so we wanted to keep him in the community, and that was my job. And one morning when I went round to his flat, I knew there was a problem, because when I put the key in the door, it was quiet. Normally there was the radio on, he was mooching about. He was a very kind of social guy, but it was silence, and there was no lights on. And I found him in the bathroom. He'd had a fall and he was unconscious, and he'd broken his cheekbone, so he was injured there, and he had a black eye, and he was in and out of consciousness, and he wasn't making any sense. We found out later that he'd knocked himself out on the sink in his bathroom because he'd fallen over. So he'd been unconscious for 6 hours, like I said, in and out. So he'd had a fall, and you know, I was devastated. I wanted to work out a way to get to him quicker when he got these falls, and I tried to solve that problem. I never solved that problem, but through trying to solve that problem, the NHS approached me and they said, could you help us solve the problem of preventing falls? So falls are a problem for a lot of us. 1 in 3 people fall who are over the age of 65. This is all around the world. But these falls can be prevented. And NICE, who are the kind of gold standard for guidelines in the UK, they've found 12 risk areas associated with falls. These risk areas range from medication to your environment, to footwear, to your walking ability. And the 50 evidence-based interventions connected to these falls. And that's what my app does. It connects carers with cutting-edge research to prevent falls. So we developed a fall prevention app for care homes, and it's been deployed in nearly 1,000 care homes, and it's prevented thousands of falls. The research says it's prevented 28% of falls compared to care homes where it's not deployed. So what this app does is it just looks at best practice. So care homes were preventing falls by doing risk assessments, and these risk assessments are on paper. Sometimes they're done informally, and we digitalize the process. And the app spits out a personalized fall prevention plan for carers. And it takes this best practice, takes the 50 evidence-based interventions. And a lot of these interventions came out of you know, the best universities in the world. Because we've collected all this data, we can find trends, what's going on in healthcare, in care homes, and these trends are of use to health systems like the NHS. We were recognised last year by the Chief Medical Director of the NHS for our work to prevent falls, and this was really appreciated during COVID. So here's some of the stats. So the care homes which have safe steps in, they have 20% less ambulance call outs. and 28% less falls. During COVID, we pivoted and we worked with Health Innovation Manchester, which is part of the NHS. And Health Innovation Manchester came to us 2 days after lockdown, and I kind of said, "What are you doing?" And we said, "We're going to change our mission from preventing falls to, how can we help solve the problem of COVID in care homes?" So with the help of the NHS and Health Innovation Manchester, we designed and deployed the world's first COVID management app for care homes, and worked with a very respected clinician and academic in Greater Manchester, Professor Martin Burnham. He's kind of like the rock star of aging and frailty and fall prevention. And we created the world's first COVID management app with him. The way to describe it is, it's like Uber for carers in care homes and GPs, the doctors. So because it was deployed so quickly, first week in April, we were able to connect residents with care quickly, instantly. So when you couldn't go into a care home, GPs could look at an app and see who was most sick in the care homes and give them the right treatment. So it was a dashboard for clinicians, and it was a very simple web app for the carers. Ask some questions such as, do you have COVID symptoms? Do you have a care plan? And it was these simple data sets that helped save thousands of lives at the peak of COVID in April 2020. And it was used a lot in Greater Manchester because of this unique data set, and we're very proud to work there. Later in the year, we added a COVID feature, a COVID testing feature, and then a COVID vaccine feature. And we've now merged it into the original Safe Steps app. We're adding new features all the time, and this is because of our partnership with the NHS. We're really proud to work with the AHSN network, especially the ones in the north. You've given us a lot of support. So that's Safe Steps. So we're a startup, and we're really keen to connect with people who want to help aging well. Thank you.
Thanks so much, Lee, and thanks for also sharing your personal story and kind of inspiration behind a lot of this work. So yeah, with that, we're actually have time now for the Q&A session. I know we've been getting a few questions here for the speakers, and I'll kind of just start going through them a little bit in order. So the first question I have here is for Greg. And Greg, there was actually two questions for you, but I'll start with one, and that's really around when you're kind of approached by stakeholders. It's whether, are you approached by SMEs or other stakeholders mostly on their own, and then you connect them, kind of using the model you described, or do you also kind of often get, ready-made projects or collaborations kind of coming to you together and looking for support and maybe funding?
Yeah, it's a good question. The answer is a little bit of both. From experience, my view has been industry will often come together with other industry partners, but with less of a clear understanding of who the other stakeholders are going to be outside, especially once it starts getting into government or larger institutional systems. I think a lot of that just sort of is an evolution of where people's focus is. Industry does tend to communicate with other industry. They tend to work with other organizations they've worked with in the past on various other parts of product development, for example. So to a certain extent, that's an easier problem perhaps to solve. It's not always, and we have been approached by companies who come to us and said, give a recent example, was a company that creates orthotics for footwear and wanted to develop a machine learning application to develop sort of an automated 3D scanning system. So no expertise in this space whatsoever, and approached us very much with open hand and said, look, we need assistance with this because we, at this point, don't even understand the things we don't understand in this sector right now. So that's sort of the most, one sort of extreme of that, all the way through to more closed ones of, we have a group of stakeholders identified who are interested in collaborating on this project. There might be some issues around project management. There may be some issues around values alignment between stakeholders. Funding, of course, is always appreciated to be able to support this as well. So a couple of different extremes on that one. I'll characterize that answer as well with what I saw as another question that I'll likely address in a second here, which is also the role of stakeholders beyond Canada. And this is a very common one for Canadian solution developers, where a lot of the technology development is being done in Canada, but everything else is outside of Canada. Keeping in mind, the Canadian economy is 35 million people approximately. The United States has 10 times the population and spends 50% more on healthcare per capita. So it's a really obvious first point of sale for Canadian companies is actually south of the border, not north of the border. And that carries additional challenges with it as well, where your product development team might be up here in Canada, but it has to work very closely inside of an American context. And so that means understanding very carefully what the value chain looks like in the United States system, how people are incentivized, how people are going to interact with the product in that context. So that's a bigger problem as well, and it's a very common one for Canadian technology developers.
Yeah, definitely. And I'll just quickly go to one other question for you, which was whether you could say a little bit more about how you support innovators with evaluation. What kind of level of resources is required there, and does that include kind of economic benefits as well as efficacy? If you could speak to that.
Yeah, and we've done both. I'll highlight Alavida as an example of this one. So the company that we've been assisting with, Fraser Health. Fraser Health Authority was interested in purchasing this application as an employee wellness program to complement what it already had in place, which is traditional abstinence and group therapy practices. The challenge here was the challenge particularly on this one is that the best case use of the trail application is in preventative health as opposed to therapeutic applications. So traditionally, an employee would only come forward after they had an identified substance use challenge. A significant opportunity and value of the trail program is that can be nipped in the bud. Everybody recognizes this, including at Fraser Health. The question is, how do you capture the value of that? How do you translate preventative health into something that actually is going to be attached to a sales figure? And so in a case like that, we actually end up partnering with health economists to associate, what information is available inside of health economics and in space in that literature to be able to link over to an estimate of what the anticipated ROI is going to be for an application like that to be made available. And so in a case like this, that was sufficient, just as sort of a rough estimate. I want to highlight that because that's an example of where values can be very well aligned, and so that process can be easier. It is much harder. I'd say the hardest challenge is inside of single payer procurement. So in Canada, this is a particularly well-known challenge is how do you take a product and ultimately get it purchased not by a company anymore, but how do you get it purchased by the province for ultimate distribution inside the health authorities inside of that province? And there it is a very, very ROI-driven decision. Effectively at that point, budgets are fully spent out. There is no free money. So any decision effectively means defunding some other choice. So not only are you having to show what the ROI is on your product, but you have to be able to integrate that against other solutions that are already in place. So that's a much, much, much harder position to be in. The other question I think was around demonstrating efficacy. So this one is a little bit, there's a couple of different flavors to that. We like to be able to do this where we can with aligned stakeholders again. So the easiest starting point for that is on Living Labs or healthy communities. So we have a number of partners who have initiatives specifically around taking early stage ventures, early stage technologies, and being able to test drive them inside of their environment. Often these are long-term care facilities that have not just a mandate for innovation, but actually an articulated and active innovation strategy, right? To be able to have some hotspot community that is intended specifically for taking early stage technologies and being able to evaluate it, and then using that as an opportunity to take feedback back to the solution developer about what's working well, what could be working better, and then how can that product be iterated to better match the values and the needs inside of that context.
Great, thanks for that, Greg. Yeah, and you obviously raised an important point there for innovators, where oftentimes they can think about things like ROI, but they don't always know enough about what's going on in the background, who they should be integrating with, what else they need to consider so that they can fit in. So thanks for raising that point too. And I know that there's another question for Greg. I'll probably come back to Greg, but I'd like to move on to a question for Michael. So Michael, a question here from the UK side is whether you could say a bit more about how you were engaged with the Wessex HSN. How did you come upon them, and what sort of support did they provide? Has it helped you make your product available in the UK? And if it hasn't, what do you think could be done to help with that?
Yeah, well, thanks for the question. Obviously, just about anything that involves working across a big body of water and requires planes and so on has been disrupted in the last couple of years, right? So I'm not sure if there are broader lessons to be drawn from that, at least that part of it. But how we initially got engaged with Wessex was we were doing some work with Merck in North America. They're actually Merck Global Health Innovation Fund is one of the investors in our seed round and in our A round again most recently. But at that time we'd done a seed with GHI, and they had referred us to a group in the Southampton area that was doing work with Hep C, which we were particularly interested in at the time, and just sort of through serendipity, we ended up speaking to the team that was working with Wessex on, or had been asked by Wessex to submit a proposal for innovative new approaches to early stage diabetes, type 2 diabetes, and it just it was purely really by accident that I happened to be in the room and overheard a conversation and said, hey, we'd love to be involved in that. Our product and technology ended up being kind of the centerpiece of the submission that was made to Wessex at the time. And I think it stood out for that reason. Most of the other pharma companies submitted proposals that looked like pharma company proposals, and ours looked like one from an innovative early stage startup company with some interesting new ideas. And I think it caught the imagination of the team at Wessex, and they very enthusiastically engaged with us in that ideation kind of process, which is so much a part of how we think about what it is that we're doing. That is not to start with, this is our molecule, and here's how you price it differently, or some tinkering around the edges. But what could we really do here? Given a year ago, given everything that is available at Wessex, let's think about how we could approach this problem differently. And we went through that process and developed I think a very interesting application, which went into some early sort of trial studies in the Wessex region with some of the surgeries around there. I think it got that, I think, was a very promising application, and actually forms the foundation of a lot of our later work in a really interesting way. It got caught up a little bit in all the noise around diabetes. There's just tons and tons of stuff that's being done there. And in fact, several important competing projects inside NHS itself overlapped sufficiently onto our project that we couldn't win support for our particular products approach, and that, you know, a different project was carried forward. I mean, I think the whole process was useful from our point of view, so I wouldn't take any of that back. But you know, it is important to point out that, you know, even when we are well engaged and we have good internal champions, it is very difficult to navigate an organization like NHS and know what is going on. There are plenty of landmines there, and we just happen to step on one, which is somebody else had a project that did a very similar thing that they were very committed to and were better connected than we were into the procurement side of things.
Right, yeah, that's fair. Sounds like some serendipity, but then also those challenges that come with
serendipity. Cuts in both directions, isn't it?
Yeah, it cuts in both directions, exactly. All right, so I'm actually gonna ask Paul a question here. You see there are a couple. Maybe I'll start with Nigel's question here. And I know you saw it in the chat, but Paul, but I'll just kind of read it out. Nigel mentioned that the programs that you described have benefited from significant government investment at the regional and national level. In west of England, there have been some challenges with getting that, and I guess Nigel's asking if you have any words of advice on how you can make a case for investment in a healthy aging ecosystem. I think that's relevant to us here in Canada too. So I'd be interested to see what advice you might have in this on this vein.
Yeah, I guess I don't know. It's another presentation, I guess, but I think the first thing is the narrative. You know, there's a kind of the story that you tell. I mean, we've seen some of the stories in the presentations, but the stories that you tell of the place in which you're working and living and serving, I think is incredibly powerful. You know, within a generation, we all know, in our business, we all know the figures, we know the numbers. You know, within a generation, the demographic profile of the places that we're in are going to change fundamentally, profoundly. And there's a gap between the action that we've been taking and those challenges, I think. And I think you can build up an argument pretty well. I think it has to be a multi-dimensional argument, though, and it has to hit a number of different targets. You know, I mean, we commissioned ILC, International Longevity Centre. I'm going to say 2 years ago, I'm not quite sure, to produce a report called Advantage GM, which was looking at the opportunities of aging populations for the GM economy, the longevity dividend. You know, and I think they said something like £250 million goes into the pockets of older pensioners in Greater Manchester every year, an increase every year. So it's about building that narrative and then getting the right actors in the room to tell that story. You know, people from different, you know, to triangulate your messages. Now, where we have been looking in Greater Manchester, I guess, is that we have a city region which has a long-standing political identity and has infrastructure that's been built up over a decade, that now has, you know, at its head, one of the best well-known politicians in the UK. And these convening powers and the storytelling and the ambitions, all that stuff is a pretty good thing. I think we also have an advantage in that Manchester is a strong brand, you know, nationally and internationally. Every time I step into a taxi, whether it's, no, not Japan, but most countries in the world, Manchester United or Manchester City, and I say, actually, Blackburn Rovers, and they're like, oh my God, what are you talking about? And then if they don't talk about that, they want to talk about music. Everybody knows about Manchester, or lots of people do. So we have a brand there. So we're lucky in a way that we've got something that people like, and trying to integrate that city story with the story of population aging, I think is the key. It's not easy, and not everybody gets it, but I think you can get enough people to get it. Just on the resource, I'll shut up after this. On the resources, I have a team, I have 2 staff funded in the combined authority, but we have lots of other people seconded into our team, and we have a wider team of 30 or 40 people that meet regularly to discuss these issues. So you can build it, you know. I think we're pretty unique in that respect. And you've got great universities in the Western, you know, University of Bristol, what I call Bristol Poly, West of England University, and so on and so forth. You've got great assets. We work with lots of colleagues down in Bristol on this agenda. Long answer, sorry.
No, I mean, it's not a simple question, I think. So thanks for that. I know there was another question that popped up for you, so and then later dropped off, but I wanted to ask it anyway because it came up a couple of times, and that was around your collaborations. So the specific question was whether you do collaborate with Age UK and the International Longevity Centre in the UK, and just to add on to that, I was curious about the general nature of your collaborations. Are you doing a lot of kind of sharing best practices with other regions? Are you collaborating on specific projects? And does that differ compared to regions within the UK compared versus outside the UK?
So, I mean, the easy answer is Age UK are a very important partner for us in Greater Manchester. They sit on one of our steering groups and are involved in many of the things that we do. And lead some programs. So in GM, they lead the work around nutrition and hydration, which has been very successful. How we collaborate nationally, I mean, we set up, so Manchester set up the UK network of age-friendly cities and communities in 2012. It has 50 members now. It's now led by the Centre for Ageing Better, which is What Works Centre in the UK. We've had a strategic partnership with them since 2016. And that's a very important platform for sharing good practice and with other cities in the UK. We're also part of a Eurocities urban ageing platform. We published a report last year, I think it was, with all the places you might want to go for the weekend. So Oslo, Barcelona, Amsterdam, and so on, and good practices. And we've also work with AARP in North America. We have partnerships with academics, University of Toronto, and others in Canada, and Vancouver as well. We've got academic contacts there, and through the WHO Age Friendly City system. It's a kind of village, really. The whole aging village. We all know each other, I guess, across the world. Right from New Zealand right through to Canada, I guess. And these projects all have very similar DNA. I think there is a challenge, though, of making them mainstream. And I think that's something that we can all work on, making this agenda something that everybody does and thinks about. I think that's the challenge.
Yeah, I would agree.
And ILC as well, yeah.
Yeah.
Strong partnership with ILC.
Yeah, thanks, Paul. So Lee, we have a question for you here. And for those Canadians in the audience, but I think also for any innovators from the UK, I wonder if you could speak to what sort of barriers you have encountered in getting more widespread adoption of Safe Steps, and whether the HSNs have helped with this. I know you kind of talked about it in the chat, but for those that didn't get to see it, if you could touch on that. And my tag-on question is, do you have plans for Safe Steps outside the UK?
Sure. So yeah, the second question, yes. So Canadian partners get in touch. But the first one, just so many barriers, so I've been working in tech for like 10, 12 years, made loads of apps for lots of industries. And some of them have been very successful. Some of them are like more consumer products, some of them for transport, and they've taken off and been downloaded millions of times. But the UK healthcare market is the hardest market or hardest ecosystem to kind of crack into. And it's because, and forgive me, colleagues, if I say this wrong, but from a kind of business person's point of view or an industry person, you're kind of seen as bad by the NHS and by the public sector. And that's cultural. And I don't know why it's like that. And, I don't know how to fix it, but there's a deep suspicion of business from the health sector, the public health sector in the UK. So that's a hard barrier to overcome. So you've kind of got to work with the system. Otherwise, you're just like, they'll put you in the same bucket as Jeff Bezos, do you know what I mean? Or Mark Zuckerberg, but you don't have the money. It's just like business bad, we're good. So what the NHS's Academic Health Science Network kind of did for us was they kind of schooled me in kind of, just teaching me how the sector works. And I probably only know 10% of it now, but people like Sig, who's on this call now, I had sort of great conversation with him last month, and he just said, look, this is what the doctors think of you. This is what the nurses think of you. This is what the commissioners think of you. And, it touches on what Paul said earlier. It's about the narrative. I might say, the ROI on this is great. We're going to do X, Y, Z. But if you get the narrative wrong, or you don't say the right words, they're suspicious of you. So the AHSN, Academic Health Science Network, kind of like a bridge between industry and the National Health Service. And it's hard to get across that bridge. I'm kind of I'm a few steps on it, but they've been like a kind of guide or a bridge or a translator or a broker. And the accelerator program, which they fund, is kind of been a game changer. We would not have the traction in the UK without the Academic Health Science Network. Simple as that. I'd be doing something else. It's that simple. So yeah, I don't know what to do without the AHSN, but they've been instrumental in our growth.
Great, thanks for sharing that. I think that covers all the questions that we received. But if others have questions, those in the audience that you come up with later, please feel free to reach out to us at Agewell or the AHSN, and we'll obviously look to get you some answers. But just wanted to take a moment now to sincerely thank all of the speakers that joined us today. Greg, Michael, Paul and Lee, thanks so much for sharing your insights. I think we learned a lot here. We touched on some themes that are really important about understanding the space and working together. And we always hear about things like communication is key, but obviously you need people willing to listen and willing to communicate, and sometimes you need others to help with that. And it sounds like both the innovators on this call and from what we heard from Greg and Paul, there are organizations that do this. So yeah, building those relationships and facilitating the building of those relationships is certainly key. I'd like to think that obviously Agewell, the HSN, and Digital Health Circle, and all the work happening in Manchester is kind of fighting the good fight and doing that. So we look forward again to engaging with those of you who have taken the time to watch, and hopefully finding ways to help you build those relationships as well. So thanks again to everyone watching, and thank you to our speakers and to Nigel as well for always joining us and helping us make this a great partnership. Looking forward to chatting more in the future.